Hi, Amy. Welcome.
Hi. Hi.
You want to take a second to introduce yourself?
I'm Amy Stumpf. I'm a speech therapist. I'm also a board certified lactation consultant. I work in a private pediatric practice, BDI Playhouse Children's Therapy in Aurora, and we do pediatric speech, occupational, and physical therapy.
Great, great. And when did you take the class?
I took the class in May of 2022 as a seat filler. I had actually signed up for it online and took about half of it, and then you came to town and you are wonderful and offer seat filler opportunities. So I jumped on the.
Great. You're cutting out just a little bit, so hopefully we can hear you. So tell me about your experience applying the work. Was it difficult for you?
It wasn't. So I took it slowly, to be honest. I will say I only really apply it with kids who are 3 and up. And I'm always constantly in communication with parents and with kids that it's a slow process. And they have to build trust with me. Kids are naturally orally defensive. And to be in that kind of position where I'm in their mouth it takes a lot to get up to that level of trust to build that.
Yeah,
I would say it's easier with my older kiddos that I work with, but still they have to consent, and we have to take it slow.
yeah, yeah. What about the whole, you know, in the class, I really stress a strong shared decision-making model,
Mhm.
which, there's gradations of that. Sometimes we can really get an active participant, and it really is about sharing decisions. And other times we have to take the lead, and whether it's with a little kiddo or a lot of other types of patient populations. Have you figured out ways to potentially figure out some shared decision making from your kids?
We do a lot of thumbs up and thumbs down.
Okay.
It's not to the level that, with my older kids, I can definitely get to, is this an 8? To me, it feels like an 8, and they can relate more to that. But with my younger friends, it's more of, is this a thumbs up or a thumbs down?
Hmm.
And we're making it more playful with that population too, because if it's an unpleasant experience, that defeats the whole purpose of it. Um,
Absolutely.
so,
Yeah.
even with the gauze, we call it a tongue blanket, and we're trying to catch our tongue in the blanket and give it a hug. And that just trying to make it more play-based and more approachable, or I'm trying to catch their tongue, or tickle the tip of it. So there's lots of different ways that we go about it, but it all has to be play-based and it all has to be, if they're not into it, we're not doing it.
Yeah, exactly. Exactly. Any other comments on the work as you've begun to apply it with the kids that you work with? I mean, it's been almost 2 years now that you've been using it, right?
Yeah, I've been recently in the past few months, I've just been trying to track a little bit of data with it. So in the myofunctional world, so I'm myofunctional trained to, we do a lot of total mouth opening, tongue tip to spot, and lingual palatal suction measurements. So
Mhm.
we've been trying to measure pre and post intervention, gains that kids have felt, or they can see, and they're really motivated by the numbers. They love to compete. They love to see their numbers get bigger. So the biggest numbers that I see, are, and this might speak to the myofunctional therapists out there. We'll get more greater total mouth opening numbers. We'll get more range with our tongue tip to spot, which is this, or we'll feel a greater a decrease in pressure when we're doing a suction, which is this. So these are all really important factors, especially with the kids that I work with who are getting tongue tie releases, which is what a lot of them that I'm seeing it's for.
Got it. Since you took the class 2 years ago, the tongue work that I taught back then has grown even more. We've now got some really I think, some really cool ways to sort of blend together the concept of stretching and the concept of strengthening in
Mhm.
about awareness. We're doing a lot of work with resistance with our fingers, both down
Mhm.
at the floor of the mouth, up the top, back and forth. I do intend to sort of add this to my tongue tips deeper dive class, but from a new learner perspective, and that I think we're definitely hitting that mark for the mouth-functional community too. Not that it replaces it or is better than, but I think I personally think that they weave together really, really well. Have you want to share some experience of yours with that?
Yeah, I mean, it definitely does. And, I always tell part of, I think the goal of me working with them is to increase strength, is to increase mobility pre-release, and then also make sure you have this gain post-release. But it's also to get them accustomed to feeling and touch in their
Yeah,
mouth. I don't want kids, and I'll tell parents this all the time, I don't want them jumping into this if they're not going to live in their mouth. It's much trauma, and we can't ask them to then have someone fighting it or to do, there's a lot of post-op stretches that are most patients that I work with use. But this is a way we can get them accustomed to touch inside their mouth, communicating what feels good and what doesn't feel good, and then knowing what the limits are, and then also just learning what that's like, so that they're okay with that when the time comes to have a release done, and then everything that happens after.
yeah,
So I think
great.
it's a good way to communicate and just build really good experiences in the mouth.
Yeah.
So.
So you were kind enough to share some videos with me that we're going to be
Mhm.
sharing in this video coming up next, about a boy that you work with. Obviously, you got written permission from the parents to share those, and we're going to be posting those. But before I do or put those up, what do you want to share about those videos?
So he graduated about 6 months ago. I had seen him previously for 2 years. His mom is a dentist, so he was the perfect kid for me to work with because we're kind of buddies in this, and she gave me just lots of leeway to have freedom to work with him and to take it slow. And so she really trusted me to work slowly with him so we could get to that level in those videos where he's letting me play with his tongue. He's letting me do some of the pulls and the squeezes and the under, lifts. The first video is about, I would say, 9 months after I started working with him. Um, he was born with a tongue tie, really small palate. So he was working, getting expansion at an early age, and then working towards being able to tolerate having what's called a functional frenuloplasty when he was 3. So here we are in that first video when he's in my lap, just working on slowly getting him used to people being in his mouth and telling me what's okay, what's not okay. And we're being playful with it. So you can hear me kind of say, I'm going to catch your tongue. Um, and then the last video is about like 2 weeks before I discharged him. So he had gotten his release done. He's an old pro at it at that time. So,
Okay.
but he had made really wonderful gains during those few years. But it was a journey of all of us kind of working together. He also started with speech delay. So we were working in speech and sound production in that time too, also getting him ready for his tongue tie race. So.
Got it.
So,
So I know watching the first video you did the that particular video without gauze. Was that during the introduction phase where you didn't want to be maybe using the gauze at that point?
I find especially for kids who have really traumatic experiences in their mouth. So I have a few kids that I work with who are on feeding tubes. There's a lot that has happened there. So I usually try to take it slow, and we introduce the gauze a little bit later. I just want them okay with me touching their tongue before we put gauze. It's a lot to ask a child to not only have my fingers in their mouth, but also to catch their tongue in gauze, which I'm regretting in that last video, I only had my really thin ply gauze. Usually I use a very thick woven gauze so that I'm not getting particles on their tongue. But kids are picky. We've got, we don't want those sensations. So I try to take it slow with introducing gauze, for
Yeah,
sure.
and we chatted beforehand too that for that
Mhm.
sort of patient, you know, children, or I don't know, there's a lot of people who that gauze is just too much. These really cheap cotton finger
Mhm.
cuts, they really fit the bill well, and you can use them just, you know, on the forefingers. Sometimes I'll get more involved, especially with some of the new techniques that we're doing. I'll glove up all of them. Like you mentioned before we went on with the filming, you know, you can use those cotton gloves, but I don't know. I much prefer these. Number one, these are dirt cheap. Those aren't, but I don't know, something about the dexterity that I really like about these. So,
Yeah.
yeah. So I'm going to break now, and we're going to. I'll be inserting the videos here into this video. So let's take a look at those.
Okay, Connor. Can you open that mouth up? Can you stick your tongue out really far? How far can you stick it out? How far? Good job, Miss Amy's gonna catch it. She's gonna catch it. I got it. I got it. I got it. I'm gonna stretch it, stretch it, stretch it. I'm gonna catch it again. I got it. I'm gonna stretch it, stretch it, stretch it. Oh, I caught it. One more time. One more time. I'm gonna catch it. And I'm gonna stretch it, stretch it, stretch it.
So you're gonna get on there and you're just gonna massage on in the middle of the tongue, on the wound. He's tighter on this side, so I'm just doing some more massage and sweeps here. Just lifting up, and then if you've got some gauze, which I can send you home with some, we're gonna catch your tongue, right, Connor? We're gonna go and stretch it out. One. So I'm getting my fingers and I'm rolling under. You give me thumbs up or thumbs down, Connor? Thumbs up? Okay. And we're just kind of pulling and lifting up. So my fingers are kind of curling under. Good job.
Those videos are great. Thanks so much for sharing them, as well as allowing or had his mom allow you to share those with us.
Mhm.
What about that experience working with kids in terms of, well, not just intraoral work, but some of this touch-based therapy?
Yeah, I mean, I feel like, you know, my goal in reaching out to you to share this, I've had those videos on my computer for a long time, and I'll show them to other parents to let them see what is possible when it's on the child's terms. You know, like, and I show them like I'm not forcing anything. It's all up to them, and it's their choice. Because again, I don't want to force anything, and we're not going to learn anything if we're in distress. So.
Yeah, exactly, exactly. And I know that it's impossible to single out one aspect of the intervention in terms of the greater whole of it. But um, is it your opinion that the manual therapy was a positive aspect of that?
Yeah, I mean,
Good.
you know, we see a relax. Again, it's also subjective, but I can feel a relaxing of tissue. Mom can, since she's a dentist, so she's kind of well versed in what that anatomy should feel like. But especially post-release, you know, when he still has stitches in there, you know, we're helping on we can feel that change in the tissue over time as we apply touch to it. So
Right.
less scar tissue, less, I always tell parents, you know, scabs kind of bunch up before they, you know, fall off. And so we're trying to prevent that from pulling everything into tension. So
Yeah, yeah. Great. So as this is a peer-to-peer type of video series I'm doing, um, is there any advice or tips that you might give, maybe somebody just learning the work or somebody sort of revisiting it from a different frame of reference?
yeah, start slow. I only started with like 1 to 2 exercises at a time. And I really just, you know, tried, you know, of course I practice on my husband and my kids, but it's different when it's someone else's kids. So communicating clearly with parents what you want to do and why you want to do it, especially, and again, with the kids, being so playful and being
Yeah,
silly. If you're going to be a pediatric therapist, hopefully, you know, you have to be playful and silly to get buy-in and to get learning to happen. So.
absolutely. Yeah. You know, a question that comes up frequently is, well, the criteria we use to determine when an intervention is an appropriate one. And I know that in academia, in the theoretical aspect of all of our works, you know, we should have sort of a decision train that we say, okay, this diagnosis here's the intervention we would use for that. But I struggle with that one because I mean, I'm a hammer and everything looks like a nail that touch could be a positive impactor with. How do you sort of wade through that dilemma of somebody asking you, well, how will you know when this person is an appropriate person to try manual therapy with?
A really great question. Well, I think we're human beings, so we're made to be touched. And as you know, kids, again, that maybe came off wrong, but we build bonds, we build attachment, we build attunement to each other through touch and through social interaction. So I think, especially as a speech therapist, you know, communication is powerful, but we attune with each other through touch. And so, you know, as we learn more about trauma and we learn more about regulation of our bodies. Like for me, touch is a big part of that. So I've got kids who are coming in and we're in fight or flight. We're really amped up. Again, I'm not going to apply those therapies right then and there, but if we can build that trust to get to that level, I feel like touch is such a powerful means of accessing some of that oral anatomy and relaxing the trauma that happened there. You know,
Yeah.
One of my friends that I work with has had a feeding tube for 10 years of her life. She was in an intensive feeding program, so much trauma around her mouth. But we were able to work on relaxing some of that and speaking to some of that. And she's only 10, but there's just so much that has happened. And so trying to rewrite that system as well through touch, I think is really powerful.
Yeah, yeah, and it definitely sounds like we're on the same plane with that. The concept of, well, what is manual therapy supposed to do, or any intervention supposed to do at that very simplistic tissue-based level that people want us to address it from, but the reality of how touch is effective with an A, right? That concept that you're talking about there, I think is so important. And yeah, I mean, maybe there is a way to sort of come up with sort of a guideline to say, here's a diagnosis, here's a patient profile. If they fail this test, then you might want to do manual therapy. But I don't know. I would love just touch, and that's what this is really, just to become embedded in all of the interventions that you as an SLP and I as a physical therapist do.
Yeah, I mean, as speech therapists, we're not really taught in our graduate, mine was a long time ago, but we're not really taught in our graduate curriculum to touch and to
Right.
And I think maybe I need that work in a clinic where I'm right next to PTs, OTs every day. So we're really, working in tandem. But we definitely have a role to play in this. And I think it is really, really powerful for us to know what we're talking about and to feel that,
Yeah.
with our clients. So,
Yeah. Great.
yeah.
Well, thanks for taking the time to chat and contribute to the series. I really appreciate it.
Yeah, thank you.
Okay.